I'm Dr. Chris Garrett, and I am a diabetes psychiatrist based at Barts Health in East London. And I'm going to do a talk today on type 1 diabetes and mental health. I'm going to just take us through what we're going to cover. So I'm going to talk about several different mental health diagnoses and how they interact with type 1 diabetes. I'm going to talk about this entity called diabetes distress, which isn't strictly speaking a mental health diagnosis, but often co-occurs with people with mental health problems and can sometimes be misconstrued as a mental health diagnosis. I'm going to talk about the associations of DK with mental health problems, and I'm talking about an entity called TIDE, type 1 with disordered eating. But first, an advert. In the UK, approximately 6% of diabetes clinics will have a clinical psychologist, but psychiatry is a much less common entity. And what we do as psychiatrists within diabetes clinics is to support the diabetes service in managing the highest risk people, the most complex people with type 1 and type 2 in the diabetes service. In our clinic, we use a population approach, so we audit the DKA episodes and people with very high glucoses with A1Cs above 100, and we use that information to decide who we should be focused on within the clinic in terms of future outcomes. I've listed there the different places in the UK that currently have psychiatry. So our clinic, Barts. There's also to the east of us, Barking and Dagenham. King's has a psychiatrist, and Centre Edinburgh and Oxford and Watford did previously, but don't at the moment. So just to continue on from that, this is a paper from Amrit Saka from 2019, which essentially divides out different levels of mental health difficulty and gives an overview of where people will be managed and who will manage them at those different levels. Level 1, level 2, essentially lower levels of mental health difficulty, which often will be managed within primary care and sometimes through talking therapies, which is the primary care psychotherapy intervention in the UK. And then at level 3, it's more into the level of secondary care psychology, often clinical psychology that's based within diabetes services, and psychiatry much more likely to be involved at level 4 and 5, higher levels of risk and more obvious mental health diagnoses such as eating disorders, complex trauma, personality disorder. So this is a slide on the associations of mental health diagnoses with type 1 and type 2. Schizophrenia is a disorder of chronic psychosis with either relapsing and remitting course or more chronic symptoms. Within type 1, there is no association between type 1 and schizophrenia. So schizophrenia isn't making type 1 more common, type 1 is making schizophrenia more common. And however, the other mental health diagnoses listed all are seen more frequently within type 1. So depression is seen more frequently in type 1, anxiety disorders, both generalized anxiety disorder and depression, seen more frequently in type 1. Eating disorders, particularly the binge eating rather than anorexia disorders, are seen more frequently in type 1. Personality disorder, particularly females, is seen more frequently in type 1, and substance misuse problems, particularly in males, are seen more frequently in type 1. This is another little advert. So this is a paper that I did 4 years ago, which explores the psychological development of people who have type 1 diabetes and tries to explain the reason why things like personality disorder and substance misuse are more frequently seen within this population. So as much as the associations are important, obviously outcomes associated with these different mental health diagnoses are also highly relevant. So schizophrenia isn't associated with type 1, but if you do have both schizophrenia and type 1, you have a much higher mortality than the type 1 population without schizophrenia. And that mortality is up to twice as high in the schizophrenia group. Depression and anxiety disorders are both associated with hyperglycemia and then the implication that there's higher levels of early morbidity in that group. Eating disorders are particularly associated with hyperglycemia, DK, and earlier mortality. Personality disorders are seen have higher DK rates and earlier mortality, and so do substance misuse. So, a kind of rule of thumb: if a person has a mental health diagnosis, they're much more likely to have a complicated history with their type 1 diabetes, and often often the mental health difficulty will predate in some way type 1 diabetes. So this is a meta-analysis from about 6-7 years ago. Looks at longitudinal papers and the association between depression and later complications from diabetes. And unsurprisingly, there is a relationship in the direction of the diabetes complication and leading subsequently on to depression. So the person has the complication, and through that potentially they have a lowering their mood and end up with a diagnosis of depression. However, more pertinently, there is association between depression and diabetes complications, and that it has a obviously from a prevention point of view is very important to recognize, because we're treating the person's low mood. The potential is that diabetes complications can be prevented, or at least they can be put off to later times in the person's life. So this is a complicated looking slide, but basically what the purpose of it is to draw out the distinction between several different entities that we see in mental health and diabetes, and to highlight the differences and the idea of their similarities. So generalized anxiety disorder is persistent, excessive anxiety around lots of different aspects of life: family, health, finances, the future. So it's kind of pervading anxiety that is there all the time, not significantly focused on diabetes, but if it's occurring with diabetes distress, it can kind of amplify it. And there is a degree of edginess, worry, and tension in the person. Treatment is with psychoeducation, CBT, and sometimes medications such as antidepressants can be used. Depression is another psychiatric condition where there's consistent low mood, loss of interest, and often low energy. And there's, in addition to that, negative cognitions, hopelessness, worthlessness, pervading feelings of sadness, and obviously that can interact with the experience of having diabetes and lead to lower self-care. And treatment again is with more psychological treatments like CBT or behavioral activation, but also there is place for medications, again, antidepressants. So finally, diabetes distress is the anxiety which comes about with living with the daily burden of having diabetes. So it's very diabetes specific, and is across different parameters. It's around the emotional side of living with diabetes. It's around the having to go to hospital appointments. It's around the physical thing of managing diet and injecting, and there it can lead to feelings of kind of chronic frustration, chronically feeling overwhelmed, and therefore the anxiety part can mimic the generalized anxiety, or the kind of more mood elements of it can mimic depression. So therefore, those the presence of diabetes distress can either emphasize the presence of generalized anxiety disorder or depression, or it can mimic it in and of itself. So diabetes distress as an entity has been recognized in mental health journals for decades. However, the codifying of diabetes distress pretty much began with the PAID scale, which was invented by Bill Polonsky approximately 30 years ago. And essentially, it's a 20-item questionnaire with several different sub-themes around treatment, food, the social element of living with diabetes, and emotional burden. And it's still used in research today. And if you're reading older papers, it will be the use of the scale that's used for diabetes distress. The scale that I use more frequently is the DDS-17, which is slightly more modern, from 20 years ago. Again, Bill Polonsky, and is 17 items, so slightly shorter, and is subdivided across the emotional burden, a kind of clinic-related burden, regimen-related burden, and the more social, interpersonal-related burden. And a significant score is a mean score, which is above 3. In some clinics, they'll use something called the DDS-2, which uses just 2 of the questions from the DDS-17 to really kind of boil down whether there is any emotional difficulties around living with diabetes. And that's just 2 questions. One, do you feel overwhelmed with managing your diabetes? And then secondly, do you feel that you're failing with managing your diabetes? And some clinics will use the DDS-2 to then feed into whether they're going to use the DDS-17. So if they don't score significantly with the DDS-2, then they will not go on to do the DDS-17. But if they have a score of over 3, then they will use the DDS-17. So what I try to do here is to illustrate how diabetes distress can manifest in different people across different points in their life. Just to start with the yellow line, which is essentially for what the experience of getting type 1 diabetes is like. So the person has normal psychology, no mental health background prior to getting their type 1. They get their type 1 diagnosis, they get a huge peak in distress around being in hospital, the kind of experience having to learn new information, the idea of how this can affect their life course. And then over time, that distress will gradually lower. And after 2 to 3 years, the person will be heading back towards baseline, but not where they started, because it's always likely there's going to be some degree of concern for themselves around their management of their diabetes. So that's a example of how diabetes distress can play on a person's mind over time. If the person is predating mental health problems, so like in the prior slide, they have anxiety disorder or depression, that means that their level of mental health difficulty was already higher than a kind of normal level. And so therefore what happens is you've got a superimposing of diabetes distress on top of generalized anxiety disorder or depression, and that can heighten the experience of diabetes stress. So the diabetes stress is higher than you would generally expect. And actually over time it is harder for the person to completely resolve their diabetes distress because of the fact that they've got underlying mental health difficulties. So in that situation, often you'll find the person has kind of more kind of chronicity in their diabetes distress over time. And finally, in the black is what I've referred to as burnout, which is a kind of colloquial word, but essentially is kind of a kind of longer term chronic feeling of diabetes distress. And I've drawn it out here as similar to the people that have grief and resolution, that there's a period, the heightened period of distress at the beginning of the diagnosis, and then there is a kind of acquiescent phase where actually things are okay, and then due to issues with wider life or with managing their diabetes in and of itself, they become burnt out by the experience and are find it much more difficult to manage their diabetes. So on the left-hand side is a something that I was part of the development of, which is the Health Innovation South London toolkit for agenda setting in diabetes clinics, and that has within it the use of the diabetes scale and how to what should flow out of using the diabetes distress scale. And on the right-hand side is a paper from Bill Polonsky's research group, which this is headed by Larry Fisher. And essentially, this is an important study because it highlights that, as I said before, diabetes distress can co-occur with people that already have mental health problems, but it also can mimic these other mental health difficulties. And so therefore, when using scales for mood, like the PHQ-9, one must be very wary of and use a diabetes distress scale as well. And if the both are shown to be high, actually clinical assessment by somebody like me is useful because it helps to tease out whether the person has depression and diabetes distress or no depression and heightened diabetes distress. So as I said before, I just wanted to pick up quickly on DKA as a mental health red flag. So there are many studies which highlight the association between DKA and mental health difficulties. The standout study is from Bryden et al. From 2003, which, although is a relatively long time ago, hasn't really been reproduced in significant numbers, and really is kind of a standout because of the level of detail of the assessments on the people that were seen, but also the length of time they were followed. So there was a study that started in the latest parts of the 1980s and followed up until the latter parts of the 1990s, and on average the patients were seen over 10 years. They had a mental health assessment at the beginning and then a mental health assessment at the end, and the key thing here for DK is that if you'd had a DK episode at the beginning of the study but didn't have mental health symptoms, you'd have mental health symptoms by the end of the study. So DK was a flag for later mental health symptoms. And if you had mental health symptoms but hadn't had DK episodes at the beginning of the study, you were more likely to have DK episodes by the end of the study. So it kind of neatly shows the association over a very long period of time, over 10 years. These other studies, most of them are database showing associations between mental health, diabetes, and later DK episodes. And also, there's a study that I did, which is a case control study looking at mental health people with DK versus people that don't have DK. And there was a very high proportion of the recurrent DK population had personality disorder. And just picking up on that, to highlight the importance of DK within this particular sub population. So these are all studies on the left-hand side which show high to kind of very high mortality at follow-up after the DK episode. And so not that mortality when the DK episodes happened, but at later follow-up. So the first two studies show mortality of somewhere between 5 and 10%, long as a national data set, as though there's a smaller ICU data set from Canada, and the other studies, Mays, Gibb, and Cow, which all came out within a few months of each other in 2016, showed at 6-year follow-up there was roughly 15% mortality after one or more episodes of DK. The Gibb study is a single center study, and they were able to subdivide down in terms of the level of DK and then look at mortality across the different populations. So if you'd so roughly 15% of the people with a DK episode had died at 6-year follow-up, and then if you'd had only one episode, that mortality fell to 10%. But if you'd had 6 or more, then your mortality was nearly 1 in 3, and that data is repeated by the national data set by Cow et al. So type 1 and eating disorders now. What I'm going to describe here is the mental health diagnoses associated with type 1, which feature a weight or overeating component. So when we read about TIDE, type 1 with disordered eating, the thing that generally comes to mind is what I would refer to as classic TIDE, which is essentially there's a kind of core feature of fear of weight gain and wanting to keep one's shape at a particular size, and that leads to restriction of insulin, emission of insulin, either through bolus or basal, and leads to chronically high A1C, a risk of DKA, other medical admissions. And the BMI is less pertinent in that kind of population. However, the non-classic group are the group that we see more frequently and have their risks, which tend to be similar to the classic group, but are less likely to be seen with at an eating disorder service. So the non-classic group is basically a group of people with binge eating and use of insulin, which it isn't structured essentially. So they're less likely to manage their diabetes well. Often both the binge eating and the chaos with the use of the insulin actually relates to mood regulation. So if they have difficulties regulating their mood, it can cause both difficulty with overeating and also using insulin in a structured way. It's more so non-classic is seen more frequently with than the classic version, and that those feelings of weight, wanting to keep manage a person's weight or shape, they kind of wax and wane over time, which is related again to mood regulation. So mood regulation is much more of a feature in that non-classic group. And finally, the restrict group. So that's a group of people who are much more of a kind of anorexia type, so much more likely to have a low BMI, much more likely to carb restrict and energy restrict, and they're much more likely to glucose, have kind of hyper glucose control. So they're more likely to have hypos rather than hypers, and much more likely to have pretty tight diabetes control and have a degree of diabetes. And I've also put on the other slide other kind of forms of eating dysregulation that we see in type 1 diabetes. So we're almost at the end. So when I was asked to do this, neurodiversity was one of the things that I was asked to pick up on. And I do think the effect that neurodiversity has on type 1 diabetes is interesting, and it's not actually researched that consistently. So this is really more kind of clinical experience than from prior research. So autism is a condition of social communication. Often there is a degree of hypersensitivity, difficulty in taking on new information, and concreteness in thinking. And often if we see that kind of cluster of characteristics in a person with a learning disability, they often actually going to find it even more difficult to take on information around managing their type 1 safely and much more likely to have a hyperglycemia presentation. However, in the normal IQ population or even higher IQ population with an autism spectrum diagnosis, actually what we see clinically is more hypoglycemia presentations, so recurrent hypo and severe hypo. And I think what's happening there is that the person has a good deal of resilience and and a normal IQ, so are able to take on certain amounts of information, but because of the perhaps from difficulty kind of with kind of concrete thinking and difficulty with flexibility around adaptation, also taking on new information from new people in their life in the diabetes clinic, they can be quite fixed in their self-management of their diabetes, and that lack of flexibility can lead to hypoglycemia in our clinical practice. So that's how autism can potentially affect diabetes management. So attention deficit disorder is a difficulty with attention and impulsivity. This group of people are more easily distracted, less able to do things more consistently, and more likely to do things in an impulsive manner. And in that group, obviously, you can imagine that the idea of a condition like type 1, which has a need for structure, a need to do things consistently, the attention deficit can often kind of get in the way with it. I think I'd say that actually IQ affects it less than I think or autism does, although I think potentially if you've got a lower IQ with attention deficit, then that's probably going to make the hypoglycemia and also DK more likely. However, the other important thing to know about with attention deficit disorder is that if the person is on some sort of catecholamine treatment, their insulin resistance can potentially go up. So the person started on ADHD medication in their 20s after a new diagnosis. You need to be aware that actually it can increase the insulin sensitivity and therefore increase in their dose. So this is, I'm not going to stay long on this slide. I just wanted to draw out the fact that particularly in people with a normal IQ, that hypoglycemia can be seen. And you can pause that and have a look at it at a later point. But basically, what I've tried to do here is kind of draw out the different features of autism and try and explain the reason why it can affect diabetes self-management towards hypoglycemia. So this is the last slide. These are two people that have been in my clinic in the last few years. On the left-hand side, a lady with chronic trauma background, and she was referred to me in 2023, at which point when I saw her, she was very, very low in mood and actually had very, very little appetite. So was not eating much, but also not taking her insulin particularly consistently. Her mood improved over the following kind of year and a half to 2 years, and that meant that her appetite improved and her eating improved, and actually that worsened her glycemic control. But it did mean that eventually she was, although she was a tricky person and had several different mental health difficulties, challenges going on, once her mood was better, she was much more able to take on the new information of being on a hybrid closed loop, and she went on hybrid closed loop last year, and you can see there that she's had an amazing turnaround in terms of her glucose self-management as a consequence of that. Now the second person is a slightly different presentation. Mainly there was a kind of chronic trauma background, and but depression was the main feature. So this is a lady that was started on a pump in 2023, and then her glucose self-management essentially deteriorated over the following year to 18 months, and then I was asked to see her subsequently. What had been missed at the time of starting the pump was that actually she was very low in mood, and because she was low in mood, she really struggled with the changes of being on a pump. There was a lot of pump fatigue, a lot of alarm fatigue. She hadn't picked up the the, the kind of nuances of managing HCl, and as you can see there, she's had a deterioration in her glucose management, even whilst having a general improvement in her mental health. The thing of managing the pump safely has really been a struggle, and she's had DK episodes as a consequence. And really, the main reason why I'm highlighting this is to kind of emphasize that actually a person does need to be in a good psychological state before started on this new technology. And I think that's it. Okay, thank you very much.